Good morning, everybody. Thank you all for coming to today's Department of Medicine's Grand Rounds. I'm one of the chief residents, Stephanie, and we have an excellent speaker lined up for today, a great topic. I just wanted to thank you all for coming out in person. I know we have great Zoom numbers, but it really does make a difference to see faces. So thank you so much. Please keep it up. I will hand it over now to Dr. Davidson, Chief of the GI Division, to give a little more background.
Well, good morning, everyone. Thanks so much for coming out on this cold morning. It's great to see you all in person. This lecture was endowed to celebrate the accomplishments of David Alpers. And this is the 24th year that we've been able to honor David's contributions and his legacy to gastroenterology, both locally and nationally and internationally. So Dr. Alpers was born in Philadelphia. He attended Harvard College, Harvard Medical School. He trained at MGH in medicine and GI. He was on the faculty there before joining the faculty at Washington University in 1969. And over the subsequent 25 plus years, built the Division of Gastroenterology into a national powerhouse of investigators and clinicians, while also establishing his credentials as a clinical investigator and a basic researcher. Dr. Alpers is credited with making some of the seminal observations in understanding brain-gut interactions, an area that he pioneered with the late Ray Klaus. Dr. Alpers also is responsible for much of our understanding of vitamin B12, cobalamin function, and its expression and regulation in the GI tract. Among his many other accomplishments, Dr. Alpers was the president of the American Gastroenterological Association and received the Friedenwald Medal, which is the highest distinction that the AGA can bestow on its members. So in honor of Dr. Alpers' contributions, the faculty and fellows in the GI division each year consider a speaker nationally who is going to reflect the accomplishments and values that Dr. Alpers helped to establish in the GI division. And this year's speaker is a truly remarkable physician scientist, Anil Rustgi. So not sure where Anil was born, but he obtained his undergraduate and medical school education at Yale and Duke University, respectively. And then he went on to train in internal medicine and GI at Mass General and was on the faculty there for many years before being recruited to the University of Pennsylvania, where he transformed that division through dedication, mentorship, and extraordinary efforts into arguably the most prominent academic division of gastroenterology in the country. Among his numerous awards and accolades, Dr. Rustgi was also president of the AGA, and he is currently the president of the American Pancreatic Association. So speaking to his impact in multiple distinct areas. So Dr. Rustgi has long been one of my North Star role models and mentors. He's just an extraordinary individual, gifted physician scientist, a tireless advocate for mentorship. He still is active in his current position as the director, the Irving Professor of Medicine, director of the NCI-designated Herbert Irving Comprehensive Cancer Center at New York Presbyterian Hospital. He still has an active lab, very interested in using organoid models of digestive cancer and he's going to talk to us today about some of his interests. The title of his talk is Inflammation, Metaplasia, and GI Cancers. So please join me in welcoming Dr. Rustgi.
Thank you so much for those overly generous remarks. Over time, I've always admired and respected Washington University as an institution, as a department, as a division, and that's certainly been reinforced again in this visit yesterday and today. So as Dr. Davidson mentioned, the title of my talk will focus more on patterns and trends. I won't drown you with data, and looking at these patterns that span chronic inflammation and the change in cell identity in tissues, what's called metaplasia, which can be a precursor to dysplasia, precancer, and ultimately GI cancers. As the previous slide indicated, I have no conflicts of interest to disclose. So Dr. Alpers, for many of us, has been the North Star. You heard about his impeccable credentials and qualifications, but his impact on medicine and science goes beyond gastroenterology and nutrition. His research has been at the nexus of many disciplines: physiology, biochemistry, nutritional biology, molecular biology, human genetics. And in that context, he has inspired many of us to follow suit. So Dr. Alpers, it's a real honor to be giving this lecture and following in your footsteps and the footsteps of previous lectures. If he's at the apogee of my presentation, everything going forward, I think, is downhill. So bear with me, tolerate my presentation, and I hope you enjoy some components of it. So if one looks epidemiologically, it's quite compelling, if not distressing and daunting. And that is if one aggregates all GI cancers: esophageal, gastric, pancreatic, colorectal, and liver, they constitute the most common cancers in the United States, almost 30%. And on top of that is layered the global incidence of GI cancers, and that's a little over 37%. So in each instance, exceeding and far exceeding incident cancers in other sites in our patients. So if we dissect that further, here I'm comparing incidence and mortality, US versus global. So you can see for esophageal, about 20,000 cases per year, but over 500,000 per year. In gastric, 26,000 in the US, but over 1 million globally. Pancreatic, 62,000 versus 460,000. Colorectal, 150,000 versus 1.9 million. And liver, 41,000 versus 905,000. And if you look at mortality, in each of these cases, mortality is approaching incidence, is equivalent to incidence, and in some cases exceeds incidence. And that speaks to many, many complex factors that are involved in both incidence and the outcome from these cancers. So what are the risk factors for these GI cancers? And I think of it as a chronic tension between epigenetic, genetic, and genomic factors versus factors that are in the cellular and tissue microenvironment versus factors that are more macro environmental. So if you look at all GI cancers, and it's applicable to most cancers in general, there's a subset that are hereditary. So there are constitutional or germline DNA mutations that are being transmitted from one generation to the next, either in an autosomal recessive fashion or an autosomal dominant fashion. So in pancreatic cancer, about 5 to 10% are hereditary, and most, but not all of these are due to BRCA2 mutations, which predispose to hereditary breast and ovarian cancer. And in colorectal cancer, that number is a staggering about 30%. The predominant inherited form of colon cancer is called Lynch syndrome, where there's an 80% lifetime risk of colon cancer, but a 40% lifetime risk of endometrial cancer and a 5 to 10% lifetime risk of a slew of other cancers. Curiously and interestingly, hereditary predisposition to cancer is quite uncommon in the upper GI tract. In esophageal cancer, a rare condition that I saw my first case just last year, it's called tylosis palmaris and plantaris. So it's a desquamation of the skin in the palms and soles, and that desquamation in the skin is associated with desquamation in the esophageal mucosa. And in gastric cancer, the less common type of cancer, as I'll elaborate upon later, is called diffuse. And there's a subset within that that's called hereditary diffuse gastric cancer that's due to germline mutations or constitutional mutations in E. cadherin. And liver cancers, people are finding now constitutional DNA mutations, but it's actually not clear if they're innocent bystanders or causative in nature. So there's a subset of GI cancers in the United States and across the world that's hereditary in nature. And a discernment of family history is critical, which can lead to genetic testing and genetic counseling and have impact on screening, surveillance, and under the right conditions, prophylactic surgical intervention. So if you contrast that then with factors that are both microenvironmental and macroenvironmental, we know still in developing countries, and certainly in the first half of the 20th century in the United States, that exposure to various chemicals, solvents, and pesticides form DNA addicts and create chaos during DNA replication. Metabolites of cigarette smoking, alcohol, either direct or indirect effects, the epidemic that is revealed through obesity, underscored by the metabolic syndrome, microbial factors, largely as the seminal studies from WashU indicate the importance of the gut microbiome in a variety of diseases, including cancers, but also viruses, DNA tumor viruses that integrate into the host genome and co-opt the host genome to augment the production of viral oncoproteins. So Epstein-Barr virus in a subset of gastric cancer, which is lymphoepithelioid, human papillomavirus in esophageal squamous cell cancer, not as much as you see in head, neck, and certainly cervical cancer, hepatitis B virus with liver cancer, and RNA viruses such as hepatitis C with liver cancer, and HIV with the whole slew of lymphomas and sarcomas. And we know with aging, there's stem cell attrition and T cell fatigue, so that the ability to replenish GI epithelia in the face of injury and an exhausted immune surveillance system is encouraging the transition to precancer and cancer. And importantly then, the GI tract is notable for being a site for not only acute inflammation, but in particular, chronic inflammation. So this inventory of chronic inflammatory conditions, and I won't belabor each one, but you can appreciate that each organ site within the GI tract, as well as the liver and the pancreas, is a constantly the target of acute inflammation. And often then from acute inflammation, there's recovery and regeneration. But if there's recurrent acute inflammation, then it sets up the stage or the foundation for chronic inflammation. And when that occurs, one of the outcomes from the chronic inflammatory state is cancer. So chronic inflammation in each of these sites and the associated cancer that's listed. So there's something about the GI tract that, by virtue of changes in the microenvironment, but in particular exposure to macroenvironmental cues and insults, that sets the stage for sort of a departure from acute inflammation, recovery and regeneration to chronic inflammation. And it could be argued there's no other set of organs in the human body that is subject to such inflammatory insult and transition to chronic inflammation. So I'm going to go through a few vignettes that I hope illustrate these principles and have great impact on our discipline in terms of trying to pursue strategies of prevention, especially through screening and surveillance in a way to mitigate against the development of chronic inflammation and prevent the transition from chronic inflammation through cancer by virtue of detection of precursor lesions and endoscopic removal of those lesions. It's an area that we're obsessed with in gastroenterology and try to have an impact. So vignette number 1, the esophageal epithelium is a stratified squamous epithelium, which is schematically depicted here. And this is the same type of epithelium that you find in the skin, the oropharynx, the trachea, and anogenital tract. So it's conserved and one of the more common or prevalent types of epithelia in the human. So at the base of the epithelium, above the basement membrane is something called the basal cell layer. This is a proliferative compartment, and there's a tiny or rare subset of these basal cells that have that are stem cells and have properties that allow for renewal of the stem cells, as well as give rise to daughter or differentiated lineages. So these cells then migrate in an outward fashion to the lumen, undergoing morphological changes and a program of differentiation. And then as these cells reach the luminal surface, they slough off or desquamate. And this process is renewed on the order of every 4 to 6 days in the human and maybe about every 2 days in the mouse. This gradient of proliferation to differentiation and sloughing and renewal triggered by active stem cells and reserve stem cells is a principle. It's a pattern throughout the GI tract. You could cross out the nomenclature of stratified squamous epithelium, change the scheme a little bit, but this is what goes on in the stomach, the small intestine, and the colon. And you can imagine then a couple of patterns. You can annotate each of these compartments through through immunohistochemistry and other platforms by certain proteins that are specific to each compartment. And you can clinically appreciate that if you injure this through radiation therapy, chemotherapy, drugs, microorganisms, then this is an onslaught into the epithelium. It now needs to recover and regenerate. Or what might happen is that stem cell integrates mutations in key genes, and there's an expansion of mutant clones that persist into precancer and cancer. By contrast, in the pancreas and liver, you don't see this proliferation differentiation gradient. Such vital organs escape this principle. And indeed, in the pancreas, it's not clear, and some argue also in the liver, if stem cells exist at all. So in each of those organs, you can injure and you get recovery. And it's likely what's happening in each of those two organs is that there's a sort of a cryptic nature to these stem cells and progenitor cells, and they're recruited in the context of injury. So they're so-called facultative stem cells or facultative progenitor cells. Very, very difficult to identify in the human and inferred through various experimental model systems in animals. So the technology that underlies induced pluripotent stem cells is where one is taking somatic cells like fibroblasts, but can take other cell types, and others now have developed exquisite protocols and techniques to take those primitive somatic cells that are of different origin, endodermal, mesodermal, ectodermal, and coax lineage specification. So in this case, you can take definitive endodermal cells and over the course of 6 to 7 weeks differentiate the tissues so you have adult differentiated esophageal tissue. And these protocols then have been done with the stomach, the intestine, pancreas, liver, bile duct, and so forth. So this is a type of technology that one should be aware or re-aware, because it allows for not only studying mechanisms, but actually drug testing and therapeutic intervention. So getting back to the fundamental aspects of the esophageal epithelium and continuing vignette number 1, there are 2 diseases that are quite prevalent, independent of acid reflux-induced esophagitis. I'm going to leave that aside momentarily, but one is called eosinophilic esophagitis, where continuous exposure to certain food allergens induces a Th2 type response with induction of certain cytokines and recruitment of eosinophils stained here. Okay, I'll come back to this. And the other is a change in identity reflecting the plasticity in the stem cells in the esophageal epithelium, where the normal squamous epithelium is replaced by an intestinal-like epithelium, so-called intestinal metaplasia. And clinically, we call this Barrett's esophagus, which then is a precursor to cancer. By contrast, eosinophilic esophagitis, in which there's chronic inflammation, so I'm going to contradict myself here from earlier comments, is that this is not precancerous. So surprisingly, this is the exception to the rule. You can have chronic inflammation in eosinophilic esophagitis, but it does not undergo malignant transformation. We're very interested, why is that? And yet, in intestinal metaplasia, one of the outcomes that we worry about is precancer, Barrett's esophagus, and cancer, namely esophageal adenocarcinoma. So a little bit more about eosinophilic esophagitis. You can see in this graph that incidence has been dramatically increasing, whether one is considering the pediatric population or the adult population over the course of the last, let's say, 15 to 20 years, which would suggest that there's something environmental as well as dietary to account for this huge induction. Curiously enough, it's a male predominant disease for reasons that are not entirely clear. And this table contrasts the clinical manifestations, a whole spectrum of symptoms in the pediatric population, but largely due to fibrosis, dysphagia, and food impaction in adults. And I would say in clinical gastroenterology, this is becoming the leading cause of emergency room consultation in gastroenterology. It takes time to diagnose it in adults, not so much in children. Food allergy is predominant in children. Food and airway allergy is predominant in adults, and often associated with atopic dermatitis, asthma, sinusitis, rhinorrhea. And this is a barium swallow showing you, instead of a smooth caliber esophagus, you can see sort of dilatations and narrowings. And then on endoscopic view, you see these circular rings and linear furrows that are reflection of the chronic inflammation that has transitioned into fibrosis. And here's a biopsy with histopathology showing you basal cell hyperplasia, as well as rich infiltration of inflammatory cells. And this schematic depiction then captures what I've been saying. So recall the depiction of the normal stratified squamous epithelium, exposure to food and or airway allergens, basal cell hyperplasia, recruitment of certain cytokines like IL-4, IL-5, IL-13. These are Th2 cytokines. Recruitment also of T cells and granulocytes. The chronic inflammation leads to fibrosis, stricture, food impaction. And EOE, or eosinophilic esophagitis, has been modeled by colleagues in mouse models. So if expose the mice to ovalbumin, it induces EOE. One can also use transgenic mouse models where one is misexpressing IL-33, a newly discovered cytokine in EOE, and that leads to EOE as well as fibrosis. And colleagues at Columbia have also misexpressed interleukin 13 to induce EOE. So there's a lot of mouse models now available that phenocopy the human disease, and then one can study it more mechanistically. And my colleagues at Columbia have also been able to take pediatric or adult endoscopic biopsies and develop three-dimensional organoids. I'm going to come back to the technical aspects of 3D organoids a little bit later, but one can see an expansion of the basal cell compartment, as well as expansion of a marker of basal cells, P63. And then if one mixes with fibroblasts, there's a crosstalk between the epithelium and fibroblasts. One sees an expansion of the basal cell compartment. So these 3D organoids for EOE become avatars also for testing drugs. And that's a huge point of emphasis between academia and industry, looking at antibodies that are specific to these cytokines, and indeed FDA approval for an antibody that recognizes IL-4 and 13. So that's EOE. Let me now shift your attention to intestinal metaplasia in the esophagus, or Barrett's esophagus. So intestinal metaplasia, again, is the replacement of the esophageal epithelium by an epithelium that looks like what's present in the small intestine, but incomplete. It doesn't have all the lineages. There's columnar enterocytes, there's goblet cells, but they lack Paneth cells as well as enteroendocrine cells. But one can appreciate this endoscopically, as I'll get to momentarily, but also histologically, see the dramatic difference between the two. And then this metaplasia, by virtue of surrounding inflammatory cues, can progress to dysplasia, low grade, and high grade, where you start seeing nuclear atypia, hyperchromasia, loss of stratification, invasion of cells into the stroma. And that high grade dysplasia can then progress to cancer. This progression from metaplasia to dysplasia to cancer is something that is a principle or a pattern in the esophagus, stomach, pancreas, but also non-GI organs such as the lung and cervix. So EOE, if one suspects it, endoscopic detection, histologic confirmation. It's estimated that Barrett's esophagus has a prevalence of 6 to 8 million in the United States. It's really hard to know because we're not screening for Barrett's esophagus in the general population, but that's the estimate. Nonetheless, if Barrett's esophagus is found in a patient, then that sets off a journey of screening, endoscopic screening, that's predicated upon whether there's metaplasia, less frequent screening, or dysplasia, more frequent screening, high-grade dysplasia, intervention, adenocarcinoma, intervention. So in our discipline, and I think those of you in non-GI probably encountered this in your practices, is endoscopic screening and surveillance for Barrett's esophagus. So the annual cancer risk for patients with metaplastic or non-dysplastic Barrett's is up to 0.4%. If there's low-grade dysplasia present in the patient, it's 1%. And if it's high-grade dysplasia, it's 5%. So endoscopic screening results in detection of Barrett's in about 6 to 12% of patients with prolonged symptoms. And like EOE, it's a male predominant disease. About 95% of Barrett's patients are men. So if there's metaplasia, infrequent endoscopic screening, perhaps every 3 years. If there's low-grade dysplasia, it's very important to confirm the diagnosis through the pathologist, and more frequently, perhaps every 6 to 12 months. And if there's high-grade dysplasia, once confirmed, one needs to eradicate it through a variety of ablative approaches. So these are pictorial depictions. So histologically, you have a sense of how the epithelium has changed, but endoscopically, what you can appreciate from the gastroesophageal junction is a cephalad progression of a salmon-colored mucosa sort of finger-like projections that can be singular or multiple, and one ends up then biopsying to see if there might be islands of low-grade dysplasia. If there is low-grade dysplasia, then radiofrequency ablation is possible and can lead to quite durable effects, although sometimes there can be recurrence of Barrett's esophagus even after that ablative approach. And if there is evidence of high-grade dysplasia, this is amenable to endoscopic mucosal resection. And in this case, there's an intramucosal carcinoma, T1, that's amenable to endoscopic mucosal resection as well. We can take these Barrett's biopsies and, much like EOE, make three-dimensional organoid systems that recapitulate the architecture of the original tissue, as well as the signatures that are present in the original tissue. So here's a patient biopsy showing you Barrett's esophagus. Can do immunohistochemical staining, looking for goblet cells with mucin. And here's the organoid reminiscent of the Barrett's, and you can stain with mucin as well. And one can then do sort of high resolution genomics on these organoids. And we've demonstrated that if one has a stiff extracellular matrix, it can actually augment the metaplasia transition to dysplasia and identify genes that are important in that transition, some of which are listed here. So I've mentioned 3D organoids, and I suspect some of you work with them either directly or indirectly. So what does it mean? This can be from mouse tissues, agnostic to the source. It's one can make organoids from a variety of different tissues, not just GI. One can obtain human biopsies or surgical specimens. And bottom line is to take that tissue and enzymatically dissociate that tissue into single cells and put them into a physical gel that's very nurturing. And that physical gel is available commercially, so-called Matrigel, or in our lab, we also fabricate or produce it, what's called hydrogel, and we can also change the stiffness in that hydrogel to impact on epithelial behavior. And then over the course of 2 to 3 weeks, these single cells then divide and increase in number. And you see islands of organoids that you can see on light microscopy here. And you can subject this to standard histology, immunohistochemistry, immunofluorescence, just like you would with human tissues. You can do all sorts of mechanistic studies, but importantly, then you can do drug screening, either with standard of care drugs or test out new drugs. So this is just sort of a journey of the organoids over 14 days, looking at the histology, looking at a marker of proliferation, looking at a marker of differentiation. And we have a whole biobank of these organoids from different GI tissues at discrete stages, normal, precancer, and cancer, sometimes ideally from the same patient. And I won't ask you to necessarily look at this in detail, but then you can do lots of profiling of these organoids at the DNA level, RNA level, and do all sorts of bioinformatic analyses and see if there are patterns then from these organoids. And what we find over and over again is that the change in the DNA and RNA landscapes have high fidelity to what's going on in the original human tissue. And we do a lot of training for others in this and share these across the country and across the world. So an illustration of this is in Barrett's, I showed you, but also esophageal adenocarcinoma. So endoscopic biopsies, enzymatically disperse the cells, put them in Matrigel, passage them, we can preserve them, and we can test drugs. So these are 4 different patients, 4 different organoids. And so as a pilot study, in which the patients in real time, real life are getting chemotherapy and radiation. And in parallel, the organoids are receiving the same chemoradiation regimen. And what one can see in these rather convoluted histograms are that in some cases, like in this one, there's a quite nice response, but in some cases, there's a lack of response. And if we correlate the non-responders in the patients, we find non-responders in the organoids, decent responders in the patients, decent responders in the organoids. So these organoids serve as avatars for testing drug response. And so if there's a lack of response, that suggests resistance to chemotherapy, chemoradiation therapy, and one can profile the organoids looking for genes that may be up. And then could those become targets? So this is just an anecdote, an illustration. We found in the EAC organoids treated with chemoradiation that a gene called BLC6 is up, and that's been shown to be very important in certain other cancers, and there's BCL6 inhibitors available. So we'd like to see in those organoids that are resistant to chemoradiation, will they respond to BCL6? So this gives you a sense of real-time application of organoid biology and therapy in the organoids with patient treatment. So that's sort of a compendium of vignette number one. And vignette number two relates to metaplasia and dysplasia in the stomach. A lot of the seminal studies coming from WashU, from Jeff Gordon's group, and when he was here, Jason Mills. So here's the normal gastric epithelium, surface cells, a territory called the isthmus, where it's believed the stem cells and progenitor cells reside, acid-producing parietal cells, and then at the base of the gastric pit or crypt are chief cells. There are two complementary approaches as to what might lead to metaplasia and dysplasia. In both cases, it's encouraged by exposure to Helicobacter pylori. In one case, if there's antralization, it leads to foveolar hyperplasia, and a type of metaplasia that's been championed by Jim Goldenring at Vanderbilt, spasmolytic polypeptide expressing metaplasia that's been reinforced through mouse models, but also found in human tissues and believed to be a precursor to gastric adenocarcinoma. The complementary approach is that H. pylori infection leads to intestinalization, the same type of intestinal metaplasia that one sees in the esophagus and Barrett's esophagus. And this leads to parietal cell loss and there's chronic inflammation with lymphocyte infiltration followed by other types of immune cells. And this intestinal metaplasia then leads to dysplasia and intestinal type adenocarcinoma, which is, remember I mentioned at the outset, 1 million cases of gastric adenocarcinoma in the world. Most of those are the intestinal subtype. Fewer are the diffuse subtype. And so this journey from normal to parietal cell loss, loss of acid production, leads to gastritis, intestinal metaplasia, dysplasia, and cancer, in which then the role of Helicobacter pylori is quite critical, and then the role of chronic inflammation is quite critical with myeloid-derived suppressor cells, T regulatory cells, and M2 type macrophages. As an aside, the NCI is now funding various centers to study this journey in much greater detail. And one of our contributions is to study in gastric intestinal metaplasia in terms of regional differences, antrum versus body versus gastricardia. But even more interesting than that is the type of intestinal metaplasia might be different based upon the population and the geographic location. So New York City, we see this traditional gastric intestinal metaplasia and dysplasia due to H. pylori. With our colleagues in Puerto Rico that are part of our study, it's actually an autoimmune lymphocytic based infiltration leading to intestinal metaplasia. So we'd like to study, compare and contrast intestinal metaplasia between the Puerto Rican population and the New York City population. Our catchment area, it's largely Dominican in nature. So this may help us understand some of the healthcare disparities that exist in metaplasia to cancer in different population groups. And so I'd like also then to remind you that intestinal metaplasia is a common feature in the esophagus and the stomach, but the way we get to it is different. Certainly the topography is different, as I mentioned, in the esophagus. It's at the gastroesophageal junction going proximally. In the stomach, it's in the distal stomach going proximally. But in both cases, there's this proximal migration of metaplastic cells. And in both cases, chronic inflammation is quite important, but the genetic underpinnings are quite different. Vignette number 3, my final vignette, is metaplasia in the pancreas. Reminder, pancreatic cancer, 60,000 cases every year. You have a SPORE grant that's studying this in great detail. Third leading cause of cancer mortality in the United States. By 2030, it'll be the second leading cause of cancer mortality. And so this is a disease that's largely attributable to aging, but we're seeing more and more cases in younger patients that are both hereditary and non-hereditary. Unfortunately, most patients present with advanced disease when symptoms are quite dramatic in terms of constitutional symptoms. And as a result, 50% of patients present with metastatic manifestations. And therefore, the overall 5-year survival for all stages is about 10 to 11%. Median survival for metastatic disease is on the order of 11 to 12 months. So here's a schematic depiction of the pancreas in terms of the endocrine compartment, and what we're interested in, the exocrine compartment. Most of the pancreatic mass, just like the salivary gland, the mammary gland, is acinar structures that synthesize, store, and secrete digestive enzymes. The secretion is into this very intricate ductal tree. These enzymes are carried in a bicarbonate-rich fluid and then placed into the duodenum for facilitating digestion. And so what can happen then in the face of injury, especially direct alcohol injury, is acute pancreatitis, very prevalent in the United States and worldwide. And what's been demonstrated in animal models is that if you injure the acini with a CCK cholecystokinin analog and other types of approaches, one can then see a transition of these acinar cells into a ductal fate, so-called acinar ductal metaplasia. The acinar ductal metaplasia can either revert back to normal acinar and ductal cells, or in the setting of chronic inflammation, can go on to develop preneoplastic lesions called pannin, and those pannin lesions can go on to develop pancreatic ductal adenocarcinoma. And each stage is associated with genetic and genomic alterations. So this is another way of looking at it. Here's the acinar cell, normal acinar cell. Here's the normal ductal cell. You injure the acinar cell, different fates can occur. It can go into an acinar ductal metaplastic state that can transdifferentiate into a duct-like cell or dedifferentiate back into acinar and ductal cells. And so histologically, you can appreciate, here's the normal pancreas, lots of acinar cells, a sea of acinar cells. You see how these islands here, those are acinar ductal metaplastic islands. And then pannin, you can start to see abnormal morphology and stromogenesis or fibrosis around it. And here's PDA. We can take these asteroductal metaplastic cells from animal models and grow them in culture, forming organoids. And we can also study these in mice. And what I'd like you to appreciate is more not the approaches, but that we can isolate cells that are asteroductal or asteroductal metaplastic cells and do single cell resolution, looking at chromatin, whether it's open or closed, so-called ataxic, and identify factors that either maintain the aster state or make the aster cells poised to undergo metaplasia. So this ADM, to emphasize, is a precursor to pre-neoplasia in the pancreas and ultimately to neoplasia. So this is a table from a review article we wrote. I've gone through with you metaplasia, dysplasia in the esophagus, in the stomach, and the pancreas, different ways to model it, different ways to intervene, especially through drug therapy. But metaplasia is something that's unique to human. You don't see it from an evolutionary viewpoint in non-human species, as well as lower organisms. And it's not restricted to the GI tract. It's predominantly in the GI tract, but you can see it, squamous metaplasia, in the lung airway by virtue of cigarette smoking, a change of columnar cells in the airways to squamous. You can see it in the cervix because of human papillomavirus infection, columnar to squamous, and other organs as well. So I'll summarize here. The GI tract, I hope I've shown you, is highly proliferative, rapid homeostatic renewal, amazing regenerative capacity due to very active and reserved stem cells. But at the same time, there's a price to pay for that high activity, and that's a vulnerability to micro and macro environmental insults. The GI tract can either adapt and revert to a normal state, or it can adapt by changing its state to a metaplastic state. And if you mix that change in identity with inflammation, chronic inflammation, you can then set up a stage for dysplasia and cancer. You can model this metaplasia, dysplasia, cancer sequence. And from a clinical viewpoint, we want to use our tools in screening and surveillance and early detection to prevent this transition to dysplasia to cancer. And I think these are opportunities from experimental biology to clinical medicine to address healthcare disparities because of the high incidence of GI cancers throughout the world. Thank you to Dr. Davidson and the GI division, and especially to Dr. Alpers. Be happy to take your questions. Thank you.
Anil, thank you so much. That was spectacular. So before I open the floor to questions, I just wanted to present this small token to Dr. Rustgi for visiting us as the 24th David Alpers speaker.
So
Congratulations. Thank you again. So questions for Dr. Rustgi? Jeff.
Really protected from organic cancer simply because the fact is the liquor response and there's no actually change in cell identity. There's all these other ones that are pretty limited, just change in cell identity.
Can you repeat the question?
Yeah. Dr. Brown's question relates to in eosinophilic esophagitis and also in eosinophilic gastroenteritis, which in our patients experience abdominal pain and diarrhea. That also is not pre-malignant. So you're right. It could be that there's no change in cell identity with eosinophilic conditions, at least in the GI tract, actually also in the lung. It's not a precursor to lung cancer. So it could be lack of change in cell identity. It could be that it's an eosinophilic response, a Th2 response. It could be that the cytokines produced are less pro-inflammatory. So in EOE, just by way of re-reminder, it's IL-4, 5, and 13. In Barrett's esophagus and chronic gastritis and pancreatic acidoductal metaplasia, it's a different portfolio of cytokines, IL-1 beta, IL-6, IL-8, which are much more pro-inflammatory and tumorigenic, and which lead to the recruitment of lots of immunosuppressive cells. And you don't see those same spectrum of immunosuppressive cells in EOE. So I totally agree with you that could be an absence of change in cell identity, but then also the type of immune infiltration is quite different. So we're very interested in sort of comparing and contrasting EOE with Barrett's esophagus. From a clinical viewpoint, when I speak with our esophagologists, they never see the coexistence of EOE and Barrett's. They seem to be mutually exclusive. In fact, my teacher, Dr. David Katska, says he's only seen one case in 35 years of the coexistence of the two. So there's something about the nature of the identity, the plasticity, the inflammation that also makes them mutually exclusive in the esophagus.
Yes, Jose.
Yeah, the question relates to these transition zones. Are they in the esophagus, but in particular the stomach, are they more prone to metaplasia? That's a great question. One, there is a proclivity for infection for H. pylori. I think that's a critical triggering event. Two, others have found and even debated the existence of more than one stem cell population in the stomach, depending upon the region of the stomach. So the cardia, very proximal stomach, in which metaplasia can occur, and actually the rate of gastric adenocarcinoma less frequent in the gastric cardia, but the rate of progression is much faster as well. And it's believed there might be a different stem cell population there than in the antrum and the body. So it could also have to do with different populations of stem cells and how those stem cells then respond to H. pylori infection and the inflammation that occurs. But that's a great question. But regardless, there's this intestinalization that occurs in the stomach. It then starts to go proximally. And I'm fascinated by the fact that that's true in the esophagus as well. It goes proximally.
Yeah.
Question, the conventional model.
So I think if I understood the question, you're using the analogy of the skin, initiation, promotion, progression. I think the same thing's occurring in the GI tract, and maybe my nomenclature is not exactly what you're indicating, but the idea of promotion is occurring in these states as well, both cell extrinsic as well as cell intrinsic. So inflammation's absolutely critical to acting as at all stages: initiation, promotion, progression, and the types of immune cells, subsets of immune cells starts to change, and you get more deleterious immune cells coming in this progression, like myeloid-derived suppressor cells, M2 macrophages, and Treg cells.
Zenon?
So it's intestinalization of the stomach, is part of sort of, that's. What's your thought for why it can be something like foveal changes stuff?
Yeah. Yeah. Yeah, the question relates to foveolar hyperplasia in the duodenum and why that doesn't trigger metaplasia and so forth. I don't know. It's a great question, but all I can say is, very broadly and non-specifically that the small intestine, there is no metaplasia dysplasia, and adenocarcinoma is quite rare in the small intestine, not only, but 5,000 cases per year. And even those are typically related to Lynch syndrome, FAP, celiac sprue. So there isn't that much sporadic or random adeno-CA in the small intestine. People think, well, it's the rapid transit of contents. It's much less populated with bacterial microorganisms than the colon. So maybe all these, and the pH is different. Maybe all those factors conspire to sort of mitigate against metaplasia and dysplasia.
Great. If it's a very quick question.
Yeah. 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 I believe the question relates to as one is making these organoids, whether it's patient-derived or iPSC, one has to use a physical gel called Matrigel, sort of an ECM. It's a problem in the field. Sometimes there's batch-to-batch variability. There's Matrigel that's growth factor rich, growth factor poor. We're using more, and I quickly mentioned it's something that we can produce. We're not the only ones doing it. It's called hydrogel. So the batch-to-batch variability goes away. It's a lot cheaper and a lot easier to use. So that may be one way, I think, to get at what you're indicating. Hydrogel is chemically defined, yes, and available commercially now.
Great. Well, thanks again, Anil. Great job. Great job.